We have, I see Anita and Barbara are both online. The webinar is starting in 1 hour, so you might not have noticed the time change or the time zone that you were in. So please feel free to. Good morning. This is Kathy Bush, and welcome to the DandleLION Medical Webinar on Mitigating Procedural Pain in High-Risk Infants, Challenges and Opportunities. We're so pleased to have Lori Brittingham join us as our faculty presenter. Lori is a neonatal clinical nurse specialist at Reading Hospital and Medical Center in Reading, Pennsylvania, and she holds a faculty position in the Neonatal Clinical Nurse Specialist program at the University of Pennsylvania School of Nursing. She received a BSN from Temple University and completed her MSN at the University of Pennsylvania. Lori recently completed her second term as a staff nurse director at large on the National Association of Neonatal Nurses Board of Directors and is currently the NAN president-elect. She has presented extensively on developmental care topics, pain management, infant bone health, and discharge process improvement. Lori, thank you so much for being with us this morning, and you're all set to go.
Thanks, Kathy, and thank you to all of you that called in to participate this morning. This is a topic that is really near and dear to my heart, and so I thank you, Kathy, for inviting me to speak today. So why is this so important for our patient population? During the past 2 decades, our understanding of pain in infants has really decreased or increased dramatically. We know for sure that repeated noxious stimuli experienced during a critical period of key brain development results in unique pain behaviors, sensory cortex activation, and neuroendocrine and physiologic stress responses in infants. Yet we continue to struggle in recognizing, respecting, and effectively treating infant pain. So our objectives for today include discussing the challenges of identifying and addressing pain in infants, discussing the growing body of evidence supporting the negative consequences of exposure to repeated episodes of unmitigated pain, and identifying strategies to prevent and treat procedural pain in high-risk infants. So my hope is that after today's session, you can take the knowledge and the strategies that we discussed back to your units and begin to implement a change in culture that will improve the lives and outcomes of babies in our care. I've got nothing to disclose and no conflicts of interest. Just to provide a little bit of background for you all around why this is such a hot topic and has been such a hot topic for us for the last 20 to 30 years, but that continues to be a problem for us, unfortunately. Lots of research has been done in the past several decades, really, and some of this data is pretty dated, but lots of research done around the fact that babies in our care continuously, or I should say consistently, despite technology and improvements in what we know and what we do and how we treat babies, we continue, unfortunately, to be required to perform painful procedures on babies on a continual basis. So just to highlight a couple of research studies that were done that I think are pretty eye-opening. Infants born less than 32 weeks gestation and less than 1,500 grams at birth were found in one study to be exposed up to 10 invasive painful procedures a day. Another study that was done several years later looked at infants born between 25 and 42 weeks gestation and found that they underwent an average of 14 painful procedures per day during their first 2 weeks of life in the NICU. And then a case study reviewed a patient who was born at 23 weeks gestation who weighed 560 grams at birth and found that that infant experienced 488 painful procedures during his NICU stay. So pretty incredible numbers when you think about that, and that babies in our care often, undergo these procedures over a period of several months of time, and some babies in some NICUs around the country up to a year of age, and then thereafter, after they leave us. So it's a pretty important issue to be addressed. Several years ago, and this probably goes back a couple decades as well, one of the pain gurus, I like to call him, Sonny Anand, worked with a group in Europe, the International Evidence-Based Group, to look at pain in newborns. And I do have this listed as a reference in the back of the slides. You guys will have access to that, and you will hear me reference Sunny and Nand at several points during this presentation. But that group came up with some guiding principles for pain management in newborns and infants. And one of the biggest pieces, and the reason for this talk today, really is that pain in newborns continues to be unrecognized and undertreated in our population. And so we know, based on the evidence, that neonates do feel pain. And this group really recommended that analgesia should be prescribed when indicated during the care of infants under our care. The second piece is that if a procedure is painful in adults, it should be considered painful in newborns, even if they are preterm. That's not something we often think about, but it is something that we should be considering on an ongoing basis. I actually had a colleague who several years ago had an LP done as part of a metabolic workup, and she said that the pain of that LP was extremely excruciating. And when I think about, how routinely sometimes we do things like LPs on our units, and, we don't think about that, and babies often, we don't pay attention to the signals that they give us to tell us that they are, having quite a bit of pain. And so I think about her story quite often when I think about, working in the NICU on a daily basis and what our poor babies are exposed to. And then the third point, and there are several points that actually came out of this consensus. I'm just highlighting a few, but the third point that I wanted to highlight was that compared with older age groups, newborns may experience a greater sensitivity to pain and are more susceptible to the long-term effects of painful stimuli than older infants and older children and adults. So something to consider as well. So preterm, I remember when I'm going to date myself a little bit, back when I was in nursing school quite a while ago. I remember them telling us pretty clearly that babies didn't remember pain, so that we didn't really need to worry about, whatever needed to be done with a baby in terms of, protecting them from pain, because they would just forget about that. But we know now that that's not true, and there have been several decades of literature that support that. Preterm infants actually have nociceptive circuitry required to perceive pain, yet the symptom is functionally immature. So it's now believed that infants have an ascending pain tract present in utero at about 10 weeks gestation. However, the descending tract may not be consistently present until somewhere between 32 and 34 weeks gestation. So what that tells us is that infants can feel pain because they have the ascending pain tract present pretty early on, but that they can't always muster up a response to pain, or certainly the response that we would expect, because that descending pain tract isn't present until somewhere between 32 and 34 weeks gestation. So another thing that makes this a little bit challenging for us and our babies. So I think that we're all fairly familiar with what infant pain looks like in the short term. We often see changes in vital signs. But what we don't often think about is that as a result of increased blood pressure, increased intracranial pressure often results, which, as we know, is a predisposing factor to intraventricular hemorrhage. So something to consider and think about. And although the time course of acute procedural pain is usually self-limiting, the effects of inadequate pain relief may be profound. Pain-induced responses may alter respiratory mechanics, increase cardiac demand, and increase contraction of skeletal muscles. In addition, there's a growing body of evidence that suggests that pain can suppress immune function and stress response. To pain may initiate hyperglycemia, increase catecholamine release, cortisol release, and antidiuretic hormone secretion. In addition, a few studies demonstrated changes in brain and spinal cord MRIs in patients who were exposed to repeated episodes of acute pain or long-term chronic pain. So, we know for sure, again, based on the literature, that pain can have very negative consequences in our infants especially. So just to review some of the common infant responses to pain, and some of these we are very familiar with. As I spoke of, the increase usually in heart rate, sometimes bradycardia is a result as well, increases in blood pressure, irregular respiratory patterns often result apnea, periodic breathing, tachypnea, things like oxygen consumption, so you'll see decreased saturations. Often you see changes in mean airway pressure. I spoke of increased muscle tone. I spoke of increased intracranial pressure. In an older baby, not necessarily a preemie, you would see some behavioral changes, things like grimacing, eye bulging, nasal flaring, quivering chin, curving of the tongue. We often see in older babies, deep nasolabial grooves. That deep kind of wrinkling of the forehead is often seen in older babies as well. Hormonal changes, so I spoke a little bit about changes in the release of cortisol and catecholamines, glucagon. Another thing that's important to consider is that growth hormone secretion is affected. The majority of our growth hormone is actually secreted during deep REM sleep. And so one of the things about pain in infants is that it's disruptive to sleep patterns. And so if babies aren't getting into, a nice restful period of sleep, for a period of time, that growth hormone is not going to get secreted. And we know that's necessary for growth and development and for brain growth as well. So that's an important thing to consider. We also see a decreased secretion of insulin in babies who are exposed to either repeated episodes of pain or chronic pain. And then there are some autonomic changes that occur. These, again, are mostly seen in older babies, sweating, flushing, pallor, and as well as the body movements that I have listed that are often seen in older infants, finger clenching, thrashing, pulling away, writhing, arching, are often seen in some of those older babies. One of the challenges that we see in our population is that preterm infants don't express pain in the same way that older infants or young children express pain, and that pain may have a more detrimental effect on preemies than term or older infants. So preemies can detect and transmit impulses, as I said, as early as 10 weeks gestation, but have difficulty organizing a response, and that is because of the absence of the descending pain track until somewhere between 32 and 34 weeks gestation. So the other thing that we know about preemies is that 50% of infants, preterm infants, don't cry after a painful procedure. They just don't have that ability consistently. Preemies have an increased pain sensitivity due to increased numbers of peripheral receptors and decreased quantity of modulating neurotransmitters, and that's, another piece that is impacted by brain immaturity and, lack of myelinization of the neurons until a later gestational age. Preemies also have less capacity for recovery stores, and their energy and their calories are depleted much more quickly. So when preemies, are exposed to something painful or stressful, sometimes it takes them hours to recover, rather than the few minutes that you may see for recovery time in an older infant. And also preemies habituate to pain a little bit more readily than an older infant might. So I'm going to talk a little bit for the next few minutes about some of the painful procedures that we perform in the NICU. And what I think is interesting, I'm going to talk about procedures that are mildly painful, procedures that are moderately painful, and procedures that are considered to be severely painful. These lists were derived from a little bit of an older publication. It was actually published in 1999, and it actually was titled Procedural Pain in Newborn Infants, the Influence of Intensity and Development, and it actually divided the procedures up into these categories. So, what I think about is being an interesting point when we start some of this discussion is that some of the things that are listed, some of the tasks, I'm going to say, that are listed here, we don't, as NICU nurses and as providers of NICU, infant care, they're not really things that we consider to be painful procedures or procedures at all. Things like a physical exam that we do very commonly. For a premature infant, that can be very painful and very stressful. For a sicker, older infant, that can be very painful and very stressful. Think about some of the infants that we take care of that have a lot of swelling and how repositioning might even be painful for them. There was an adult study done several years ago called the Thunder 2 study, and they actually looked at patients who spent time in an adult ICU and asked them to rate the top 5 most painful procedures that they underwent during their stay. And they did rate things like repositioning, removal of lines and tubes, and endotracheal tube suctioning. And when you think about it, those, again, are things that we don't necessarily consider to be procedures. We consider them to be tasks that we need to complete, but for those patients, they were considered to be very painful. Another thing that's on this list is insertion of a feeding tube or gavage tube for gastric decompression. And that's something, again, that we do very routinely in caring for infants, and we don't necessarily think of that as a painful procedure. Placement of umbilical lines, some of the cultures that we do, sometimes on admission, sometimes during a baby stay, eye cultures, nasopharyngeal cultures, bladder catheterization is on this list, as well as a hearing screen, which 100% of our babies now get prior to discharge to home. And in a term baby, that period of time when they're undergoing a hearing screen might not be too significant, but for a preterm infant who has already been exposed to many procedures during their hospital stay, that can be considered a painful procedure that really just adds stress to their whole picture and potentially their outcomes. So the next list is the moderate list, and things that you would expect, I think, belong on this list or live on this list. Things like arterial puncture and venipuncture. And arterial punctures are actually considered to be pretty painful because the arteries contain nerve endings where the veins actually don't. So arterial punctures and arterial sticks or cannulations should always be considered a little bit more painful than a venous stick. Heel sticks live on this list. Tracheal suctioning. So endotracheal suctioning is another one of those tasks that we complete on a very regular basis that we don't necessarily consider to be a painful procedure. But if you start to do a lit search, you will find lots of evidence that, this in adults and pediatric patients has been identified that's something to be really painful. And so we need to think about that when caring for our babies. Intubations, of course, I think that's a subject that's gotten a lot of attention over the last several years, and lots of facilities are doing rapid sequence intubation now to try to help infants with the stress and pain of that procedure, so that's a nice positive. Any kind of injections, so immunizations, sub-Q injections, vitamin K, hepatitis B, any of those frequently administered injections need to be considered painful. Some central line removals, PICC line removals, some units Dubroviacs, those can be painful when they're removed. Thoracentesis, that's expected. Surfactant is expected. I'm sure we've all witnessed babies who have received surfactant and had a negative response to that for a variety of reasons, pain being one of them. Suture removal. Extubation is on this list, so we often at this point think of intubation as being something that's painful for our infants, but we don't often give the same credit to extubation. And then percutaneous ventricular taps are on this list as well. So on the list of severely invasive or severely painful, things like arterial or venous cut-downs, arterial catheterization, I spoke of that. Circumcisions are on this list. We all do those pretty frequently. Lumbar punctures. Here's a surprise. Eye exam for retinopathy of prematurity. I think that we all assume that those exams are very stressful for our babies, but we don't necessarily think that they're painful. And they are lots of evidence, to support the fact that they are painful for babies, and we need to think about that. Bronchoscopies and endoscopies. bladder taps, central line placements. I think we're all pretty good at pre-medicating babies prior to central line placements at this point. And chest tubes are something on this list that are pretty expected. We know that placement of chest tubes as well as indwelling chest tubes can be extremely painful for our babies. So in terms of pain intervention and what we can do to help babies, and this again, these are some recommendations that were put out by that international evidence-based group that worked with Sunny and Nand in Europe several years ago. They suggested that environmental and behavioral interventions are the foundation of pain management for infants, and we'll talk about why that is. Pharmacologic pain intervention should be additive, and that a combination of non-pharmacologic and pharmacologic interventions minimize pain and stress and maximize infant self-regulatory capacities. A little bit more specifically about each of these. So some of the interventions that are fairly effective in reducing pain responses in infants include reducing harsh lighting in our environment and reducing noise. I think those are well-known, well-researched interventions. And I think, at times there are, during certain points of the day or certain, times of the day or during certain activities, we think about decreasing lighting in the room. We occasionally think about reducing noise, but I don't think we do a good enough job of that. And I think it's something that, when you're talking about a healing, restful environment, that's something that we all need to consider. If you think about admissions, which are, an area that we still struggle with, or when a baby gets sick and you need to perform lots of interventions and there's lots of people around your bedside, sometimes those can be the most difficult times to try to get a grasp and modify the environment a little bit for the baby's comfort and, to decrease the baby's stress level. But we need to think about that because those two strategies, just reducing the harsh lighting and just trying to reduce some of the noise in the environment, can be really effective in preventing stress and pain in our population. Reducing the frequency of handling is another point to consider, really thinking about your baby's day. If your baby needs an eye exam and they need labs drawn and the mom's going to come in this afternoon and want to hold, think about how you can structure that baby's day if you can. The eye exam is going to happen at a certain time. Whenever that ophthalmologist arrives at your bedside is when it's going to happen, and you don't often have much control over that. But you may have control over other pieces of your baby's day. And so when you come in the morning or, the evening and get report and think about what do I have to do, it's not always about what you have to do. It's about what can you do to try to make your baby's day the least stressful and the most pain-free that you can. So really thinking about that structure and what you can do to make it a little bit better for babies. And limiting painful procedures. So thinking about things like grouping lab draws together or eliminating lab draws. If you have a blood gas due at 8 a.m. and a CBC, your 12-hour CBC with DIF due at 10 a.m., can you talk to your medical team and collaborate a little bit and draw both at 9 or draw both at 8 instead of sticking that baby twice and causing two painful experiences instead of grouping those together and just doing one lab draw. Or eliminating lab draws. In the unit where I used to work, and this is going back a few years, on all of our critically ill infants, we used to get daily labs and daily chest x-rays. And we got to a point where we really evaluated that and decided that we really didn't need daily labs and sometimes not daily chest x-rays on those babies because we weren't doing a whole lot with the results. So for some of those babies, we went to drawing Monday, Thursday labs instead of daily labs. So things to consider. Environmental and behavioral interventions are really thought to reduce neonatal pain indirectly by reducing the total load of noxious stimuli on the infant and directly by blocking nociceptive transmission by activating descending pain modulation systems. So these interventions in infants can be really, really, really successful if implemented the right way. In terms of behavioral interventions, this group has been very well researched. over the past few decades. So things like, when you go to do a painful procedure, speaking to the baby in a soft voice, or if the mom is present at the bedside, maybe singing to the baby or just speaking to the baby softly prior to the procedure or during the procedure. Providing pleasant smells for the baby, sometimes a little cloth with a few drops of breast milk near the baby, or having the mom, again, present at the bedside. The baby can perceive the mom's presence. They can hear the mom's voice. They can smell the mom and be comforted by that. So these methods actually work because they're providing competing stimuli and blocking the perception of pain in infants. Things like non-nutritive sucking, that's an intervention that's gotten lots of attention over the last few years, as well as use of sucrose and breast milk to mitigate procedural pain. Facilitated tucking, that nice containment that we provide with our hands. And we're going to get into a little bit more detail with each of these interventions. Skin-to-skin contact. There have been several studies that looked at babies' response to heel stick while mom was holding skin-to-skin, and those babies had a greatly decreased response to pain during skin-to-skin contact. Massage is something that's gotten a lot of attention over the last few years, and some units are now hiring massage therapists to be present on the unit. And some of what they're looking at is really providing massage therapy during painful or stressful times. So lots of evolving research in that area. And then vibration is something new that I actually just heard about at the NAN conference in October in Dallas, Texas. There was a group that presented on the use of local vibration during heel sticks, and although it was just a pilot study, it was really interesting, and this intervention actually was fairly successful in decreasing the pain response in infants who received the intervention and were exposed to heel sticks. So I'm thinking we'll hear more to come on that within the next couple of years. A little bit more on sucrose, because I think it's probably one of the most popular interventions, although we do not use sucrose consistently as we should for some of the procedures that we do. Most of us at this point are pretty familiar with the use of sucrose. It's one of the most studied behavioral interventions. I think that most of us are currently using a 24% solution. Consists of glucose and fructose, and it's usually administered at this point via a bullet, a single-use bullet, or a multi-use cup with oral syringes. Sucrose is believed to work in at least two different ways. It's believed to be a very powerful distractor for infants. In addition, there's thought that administration of sucrose leads to dissociation between sensory and affective elements of a painful experience. And so lots of research in both of those few areas. If you actually search sucrose, you'll most likely find hundreds of articles or hundreds of publications regarding the effectiveness of sucrose in the NICU population specifically. Research has demonstrated decreased crying, decreased facial expression, and dampening of physiologic responses such as heart rate, desaturations, changes in respiratory pattern, specifically breath holding, apnea, tachypnea, those types of responses in infants who receive this intervention to mitigate procedural pain. So lots of work done in this area. When it comes to dosing, I think probably everyone out there is doing something a little bit different at this point. There was a Cochrane collaboration done on the use of sucrose, and they did address dosing. They're specifying a dose range of 0.5 to 2 mLs of sucrose per procedure, so that's a pretty wide range. At this point, I tend to prefer using loading doses, and I can speak to that a little bit if you all have questions at the end. In both of the facilities that I've worked in recently, we have used loading doses, and so I kind of included an example of how we load and subsequently dose our babies. In infants less than 40 weeks gestation, but greater than 30 weeks gestation, I'm suggesting a loading dose of 0.5 mLs 2 minutes prior to the procedure, and then you can give a couple of drops or what measures to be 0.1 mLs at 2 points, either during or after the procedure. And then in infants greater than 40 weeks up to 6 months of age. Some places do up to 12 months of age. I think there were a couple of recent studies that looked at the effectiveness of sucrose past the 6-month point, and those studies were actually provided pretty positive results in that older population of babies. So in babies greater than 40 weeks up to 6 to 12 months of age, I would consider a loading dose of 1 ml 2 minutes prior to the procedure, and then subsequent doses of a few drops to 0.1 ml during or after the procedure. And just keep in mind that these dose recommendations are actually per procedure. So if you are placing a peripheral IV in an infant and need to stick that baby twice, each stick is considered a procedure so that you can repeat the whole thing twice for that infant. But do be cautious not to give, I would say, more than 10 doses of sucrose in any given day. So documentation is important. We need to keep track of how much sucrose we're actually giving. I do want to mention, while there are hundreds of publications regarding the effectiveness and safety of sucrose for procedural pain, it probably wouldn't be fair if I didn't mention that there are a few studies that have raised concerns, and one of those studies did look at babies who received greater than 10 doses of sucrose per day, and those infants were found to have altered neurodevelopmental outcomes at several years of age. And so, that needs to be considered, and you need to be cautious about how much sucrose you are administering over the period of a 24-hour period of time. So the onset of action for sucrose is about 10 seconds, and the peak is 2 minutes, which is why we suggest giving your first dose, your loading dose of sucrose, 2 minutes prior to the start of your procedure. And then the duration of action is 5 to 10 minutes. For most short-term, fairly quick procedures, sucrose is a very, very effective method of mitigating pain. Excuse me. I often get questions about, who can have sucrose, who can't have sucrose. I already talked about gestational ages, babies topping out at between 6 to 12 months of age when it becomes less effective. But I often get questions about intubated infants, and, people are worried that intubated infants could potentially aspirate sucrose, but I think it's all in the administration. So if it's administered into the buccal cavity, into the side of the cheek, and it's administered at a pretty slow, consistent rate and allowed to absorb from the mouth, it should be safe for intubated infants. I once had one of our attending physicians tell me that, or ask me, why are we so worried about oral sucrose in an intubated infant? Intubated infants often swallow up to 30 mLs of their own secretions over the course of a day. So that little bit of sucrose isn't going to harm the infant. If they do swallow a little bit, it's fine. They're most likely not going to aspirate if they're just intubated. Infants who are NPO can have sucrose for painful procedures, but not for hunger or irritability. That's another common issue that we hear about, is that, staff often use sucrose to calm an irritable baby. Some of the NAS population, this happens pretty frequently. And what we have to keep in mind is that sucrose really works because we're just giving it for a painful procedure. If we give it all the time for a baby who's hungry or irritable, it does not work. Babies habituate to it eventually. So you're really defeating the purpose. Get lots of questions about babies with necrotizing enterocolitis or at risk for necrotizing enterocolitis. Again, if you're administering sucrose the proper way into the oral cavity and it's absorbing from the mouth, it shouldn't reach the belly and shouldn't cause any increased risk for complications. And then just consider any baby who has glucose instability. There's lots of literature that kind of supports that glucose levels or blood glucose levels remain stable with infants who receive sucrose. But, it just depends on how much you're giving and if it's going to have an effect. One of the institutions where I worked had a pretty large population of babies with hyperinsulinism, and those babies were getting heel sticks for blood glucose levels every hour. And, of course, we couldn't provide the sucrose every hour. That would exceed the recommended dosage per day. But there was concern that if we were giving it that frequently, that it might at some point alter their blood glucose levels. So be careful in any infant who has glucose instability and any infant who would be at risk for aspiration, like a baby with unrepaired tracheoesophageal fistula or a baby who is heavily sedated or paralyzed. And I think those babies at this point in time are few and far between, as we've tried to get away from using those types of medications that heavily. So I often get questions, too, about babies who can't have sucrose because they're less than 30 weeks gestation. There are some studies that have documented safety and effectiveness of sucrose down to about 27 weeks gestation. And there are plenty of institutions that are administering sucrose in that younger population, and it seems to be just fine. I don't know of many who are administering sucrose to babies less than 27 weeks gestation, and so for those babies, I might suggest pacifier dips in breast milk, because breast milk is another one of those interventions that has been researched quite a bit and can provide an alternative to sucrose in babies who can't have sucrose, or sometimes you have a situation where there's a mom who doesn't want their baby to have sucrose, and if she's pumping breast milk, that's a great alternative and something to think about for those babies. Facilitated tucking, we've talked a little bit about. I just wanted to show you a picture for those who are unfamiliar with this intervention. There's lots of great research around facilitated tucking and containment during painful procedures and the effectiveness of it. Specifically endotracheal tube suctioning. So that's one of those interventions that we talked about that is potentially very painful for infants and very stressful. And you don't often have a lot of time to, provide another intervention to mitigate the pain of that procedure. And so facilitated tucking is something that you can actually provide to a baby pretty easily. If there's a parent sitting at the bedside, it's something that they can do for the baby and feel that they're supporting and helping their baby. So it's a great thing to teach them. And when it comes to pharmacologic pain reduction strategies, another lecture for another day. We don't have time to get into too many of the pharmacologic options at this point. And pharmacologic, again, really should be your last, you should always do the behavioral and the environmental interventions. Use those first before adding pharmacologic intervention, unless you're doing something really painful, like a chest tube insertion, like a central line insertion, like an LP. Those things require pharmacologic intervention. But over the last few years especially, there's been lots of many studies looking at the detrimental effects of opioids and sedatives. And so some of the more recent publications have looked at opioids actually causing reduction of neuronal density and dendritic length, as well as apoptosis, which is programmed cell death. Has been observed in rodent models of early opioid exposure, so something to think about. Early opioid exposure also is thought to compromise myelinization. And then as far as sedatives, midazolam, we've known for probably a couple of decades now that midazolam or Versed has been associated with disruption of neurocognitive function, especially when used in young preterm infants. But there's an emerging body of evidence looking at all of the benzodiazepines, suggesting that the benzos, the midazolams, the lorazepams, the diazepams, cause cerebral apoptosis. when utilized during any point of infancy. So not that I don't want you to consider pharmacologic pain management for certain things, but I want you to consider always using behavioral and environmental interventions prior to just thinking about pharmacologic management for some of the short-term procedures that we're discussing today. Another thing to consider regarding sedatives is that sedatives do not provide pain management. They only sedate an infant. So if you're sedating an infant and not appropriately providing pain management, like an opioid, you're potentially exposing the baby to pain, but they can't muster up the painful response because they're sedated. So you're not really providing what you need to provide for that baby. And then the third pharmacologic piece that I want to spend a little bit of time on is topical lidocaine preparations. So topical lidocaine solutions, we used to think of, this is EMLA actually. EMLA was the most popular brand name that came out several decades ago and was used pretty frequently in lots of children, even in adults with certain procedures. We typically don't use EMLA at this point in our population because it contains a preservative, which can have negative consequences for preterm and term younger infants. The two preparations that I know of that are used pretty frequently at this point are LMX4 and Anacream. They're both brand names. So these are both lidocaine creams. They work really well with procedures such as LPs, immunizations, injections. I believe that both of these brands, and check with your hospital, you may have a different brand or a generic brand that has different recommendations, but with both of these brands, I think that they are or can be used effectively in babies greater than 30 days of life and greater than 30 weeks gestation corrected age. What happens with these preparations is that you do have to, think ahead of time if you're doing certain procedures. You have to plan ahead. You have to have an order for this because it is considered a medication, and it needs to sit on the area where the procedure is going to be performed for about 20 to 30 minutes prior to beginning the procedure. So you do need a little bit of time. It's usually applied directly to intact skin and covered with a piece of Tegaderm, left in place for that 20 to 30 minutes, and then the Tegaderm is removed. You can use gauze to wipe the area and then prep your area with alcohol or ChloraPrep for whatever procedure that you're going to perform. So there are dosing recommendations for each of these. I just gave you an example of Anacream. It's weight-based dosing, so babies under 5 kilos can get 0.5 grams to 1 gram. Excuse me, and babies 5 to 10 kilos usually get 1 gram to 2 grams. They come in little foil packets usually. You can repeat a dose of lidocaine preparation in a period of 2 hours, but it cannot be applied more than 3 times per 24-hour period. Again, just to reiterate, some of the procedures that lidocaine preparations work really well for include any kind of injections, whether they be sub-Q, immunizations, LPs, they work really well for. I have seen the topical lidocaine preparations used for older babies for venipuncture, like for weekly lab draws. That's really difficult to do for venipuncture in preterm infants and some of the younger infants because you're often sticking more than one vein to try to either draw a specimen or place an IV. So it's difficult. But for some of the older babies, for weekly lab draws for some of the long-term kids, it actually works really well. And then some institutions are actually using lidocaine preparations for circumcisions instead of doing the injectable lidocaine, and some institutions are actually doing a combination of both. They put the topical lidocaine preparation on the site for a little bit of time, and then they do the injections. Because keep in mind, some of those injections can be painful as well. So the topical lidocaine solution or preparations actually help a little bit with that pain. So I know I had the slide previously, but just to reiterate again, because I think this is one of the most important points of this lecture, environmental and behavioral interventions are the foundation of pain management for infants. Pharmacologic is additive, and a combination of the two minimizes pain and stress and maximizes self-regulatory behaviors in our population. I'm kind of going to wrap up with talking a little bit about a protocol that I was involved in developing a few years ago. It actually started as a protocol to support babies during ROP exams, and we adapted it to be able to use it for any procedure. My belief, and if you look at the literature that's out there on infant pain management and all the environmental and the behavioral pieces that we've talked about over the last few minutes, there is research on each of those and the effectiveness of each of those. But I feel that when you combine a lot of those interventions, when you use several of those interventions at once, that they're a lot more effective than just using 1 to 2 of those interventions. So this procedural protocol actually kind of combines all of the environmental and behavioral interventions that we've talked about over the last little while. And I actually have it divided up into 3 phases, and this, again, can be adapted to any bedside procedure that you're performing in the NICU. Even LPs, even, chest tube placements, things like that, with a little bit of, thinking and planning. So phase 1 is prior to the procedure. You're going to think about your environmental pieces, dimming your lights, trying to decrease the ambient noise around the baby's bed space. Think about that topical lidocaine if the baby's greater than 30 weeks, if the baby's having a procedure like an immunization or an LP done. Think about that, because you usually have a little bit of a heads up. You have some time to be able to plan ahead and ask for an order and get that topical lidocaine preparation on your procedure site prior to performing one of those procedures. Then think about getting the infant in a comfortable position, swaddled if possible. If not swaddled, if it's a small baby in an isolette, think about using your positioning aids. Think about using your blanket rolls, getting the baby in a nice midline, supine, or side-lying position, whatever the procedure determines that baby to be positioned. Preferably hands up near the face. Use your blanket rolls, your positioning aids to facilitate and maintain that nice positioning. Get that baby in that position well before starting that procedure. And then try to give the baby a period of rest prior to starting the procedure. And while you're giving the baby a period of rest, think about gathering the supplies that are going to be necessary. Think about finding someone to help. If it's, a physician or an NP coming to do a procedure at your bedside, can you be the second person not to help them, but to support the baby? One caregiver needs to be present just to support the baby, not to help the provider with the procedure. So you may need 3 people present, but think about identifying someone who can just be present at the bedside to support the baby. That person will be responsible for providing, hands-on containment, supporting a pacifier, re-administering Sucrose if you're using Sucrose, and then think about administering your Sucrose 2 minutes prior to the beginning of the procedure so that you can get that nice peak when the procedure begins. Okay. Again, if you can't use Sucrose, think about pacifier dips in human milk. Phase 2 is during the procedure. So as the procedure begins, that second person, that's dedicated just to the support of the baby. And again, depending on the procedure, that might be a mom or a dad at a bedside. It's a nice way to pull them in and involve them. If you're doing an immunization and they don't mind watching, or you're doing a heel stick and they don't mind being there, that's a great time to get them involved and get them to help support their baby. So providing a soothing voice and gentle touch, maybe stroking the baby's head. And then providing hands-on support during the procedure. So that nice facilitated tucking. With many of the procedures, you should think about, tucking a baby's legs up near their belly with a nice rounded back. That nice flexed fetal position we think about is the most supportive position for a baby. And you can modify that based on, what area you need to access for the procedure that you're doing. If you can, think about, again, getting that baby's hands up near their face, letting them hold your fingers, or having them hold, performing that nice hand clasping where they're able to grasp their own hands together to provide support and self-calming behaviors. Continue to offer a pacifier and provide subsequent sucrose dosing as needed. And then to constantly be looking at how that baby's tolerating the procedure and then communicating how that baby looks to the person who's performing the procedure. So if the baby begins to decompensate and, there can be a pause in the procedure. Now, that can't happen with every procedure, but some procedures it can. So can we pause? We do this a lot with eye exams. If the baby starts to deteriorate, we ask the ophthalmologist to take a little bit of a break, and they usually do that for us. So you're keeping an eye on the heart rate. You're keeping an eye on the SATs. You're keeping an eye on the baby's stress cues and how that baby's tolerating and communicating that to whoever's performing the procedure. And then phase 3 is following the procedure. Again, if a parent is available and present at the bedside, and this, of course, can't be every infant. It depends on their level of illness. But if they can hold the baby for about 30 minutes following the procedure, that's great. If they can do skin-to-skin, that's great. If they can't hold the baby, can they sit next to the bedside and just do some hands-on containment with that baby? Again, a great activity for a parent to do at the bedside. If a parent's not available or not at the bedside, think about who can be. Can that second person who's at the bedside supporting the baby, can they be that person who stays with the baby for a little bit of a period of time after the procedure to reposition that baby, offer their pacifier, kind of support them until they return to their baseline status before just leaving the bedside. And then trying to allow for a period of at least 30 minutes of undisturbed rest following the procedure, minimizing, again, the lighting and the noise in the area. And I think I'm coming up on my time, so I just want to quickly review, and then we can take some questions. Some take-home points. So despite some of the challenges that we talked about today, it's really our responsibility as healthcare providers to assess and manage infant pain using the appropriate environmental, behavioral, and if necessary, pharmacologic interventions to prevent, reduce, and eliminate neonatal pain. Planning ahead and engaging team members is very crucial to us. And I challenge you. I challenge you all to, I feel like you probably joined this webinar today because you had some interest in pain management in infants. So I'm hoping that you will take what you learned today and go back to your units and advocate for infant pain management. Get everyone on your units thinking about why this is so important and why we need to really act on what we've learned here today. So that's all I've got. I did provide some references, and I provided my email address as well. If you want to email me, I can provide additional references. I can talk to you individually, but I do think we have a few minutes to take questions at this point.
Yes, Lori, thank you so much. That was really awesome. Lots of great information and, very specific, which I think was really terrific. We do have time for questions now. I'd like to introduce Kathy Sally Randall. She is our CEU provider, and she will help to moderate the questions. So, Kathy, I'm going to turn it over to you, and Lori will take as much time to answer as many questions as we can.
Okay. Yeah, so thanks, Kathy. There were just a couple questions, so if you haven't put your questions in yet, go ahead and type them in the chat area. There was just one question about circumcisions, and maybe you could go back to that slide and just reiterate kind of what your current recommendations are for pain management and even local support during the circumcision.
Okay. In terms of lidocaine use?
Yeah, so this person was saying that they use Elemex, and your other slide was saying that wasn't recommended until 6 months, so she was confused as what maybe the best practice should be.
Okay. Okay. So there are a variety of different brand names of topical lidocaine preparations. The one that's not recommended in infants, and I'm not even sure of the age cutoff, is EMLA, E-M-L-A, and that's because it contains a preservative. There are two others that do not contain preservatives, LMX4 and Anacream. And so those both of those preparations can be used pretty successfully, not in babies less than 30 days of age, because we try not to use any preparations for that population of babies, or babies less than 30 weeks gestation. And those are the manufacturer recommendations on those two products only, is not to use less than 30 weeks gestation. There are other products on the market that may have different recommendations, so you should always, if you're using different products, look at the manufacturer guidelines. Some of those products may have preservatives or may have different recommendations. That answer the question?
Great. Yep, I think so. And I'll have Sharon, if you have additional feedback or want more clarification, you can type in some questions.
Okay.
Let's see, I'm trying to see. People are just commenting to yes about the eye exams.
Now, I'll make a comment about the eye exams, too, because I had hoped to be able to, run a video today, but unfortunately, I couldn't get in touch with the family to get the appropriate consent to have it broadcast on the Internet. But I did have a video of a baby who we utilized our support protocol for, and that baby actually, it's really unfortunate that I couldn't show it because that baby actually slept through the entire eye exam. And I've had babies using the support protocol that have slept through IV sticks and different procedures when you do, the whole procedure start to finish. So it's actually a very successful, it's hard to, I'd love to study it, but of course then we'd have to be unethical knowing that, holding back from that level of support with some babies for our control group. Right. But it's been a really successful venture, that protocol. So I honestly would, suggest that if you have the opportunity to try that, you give it a shot.
Cool. The other thing I was going to mention, someone commented when you were talking about the vibration that it seemed like they had an experience using it in their unit, and that the effect seems to wear off over time. They had a baby who was getting daily shots, and so they were using it daily, and they felt like after a couple weeks that the baby seemed to kind of habituate to it. So do you remember if you've heard of that before? I mean, it kind of makes sense, of course.
No,
but
I haven't seen anything published on that, to be honest with you. I only spoke of a 15-minute paper, or I guess it was a half-hour paper presentation that was presented at NAN just in October, and I don't remember that being, one of the pieces that was brought up. But I know they're trying to publish their study too, so that may come up.
Yeah, I mean, I think it makes sense, right? I mean, we all can habituate to things, right, and relate that positive with that negative, so I'm sure it could happen. I'll wait for some other questions, but do you want to talk a little bit about your loading dose of sucrose?
Sure. So I've had experience with loading doses for several years. I worked at an institution where I was the developmental care committee chair and was approached by one of our attending physicians who said, I think we're underdosing our babies with sucrose. And I said, oh, no, they're doing fine. I mean, we were pretty impressed with, we were using sucrose pretty consistently and pretty impressed with the level of effectiveness that we were, able to achieve. But she said, no, I honestly think we should really look at the literature and decide if we're not giving enough. At the time, we were only actually providing pacifier dips. We were doing the 2 minutes prior to the procedure, but we were only doing, like 2 to 3 dips during that period of time. So we actually did a little bit of a QI project, and we reviewed all the literature, and we decided, yes, we probably were underdosing our babies a little bit. There were those of us that were a little bit skeptical and thought, oh, we're doing a fine job. So we actually started with the loading dose and found that it made such a difference for babies. Honestly, a lot of them sleep through bedside procedures. when you give that loading dose. If you do, the swaddling, the hands-on containment, the sucrose, the dim lighting, the reduction of the ambient noise, all of those things, they do really well with that. We've had great success, and I just actually left my old job and started a new job, and we're in the process of switching sucrose policy here to, reflect the loading dose as well.
Great. If there are any other final questions, you can type them in the chat area. Looks like the chat area maybe disappeared there for a few minutes, so I'll give people another couple seconds. Okay, there's a couple more here, Lori. So how do you talk to families about pain support?
Well, it's a Joint Commission requirement that we're addressing it. I think the most effective way is to be open and honest with parents that their babies are going to be exposed, unfortunately, to painful and stressful procedures while in our care, and that there are things that we can do and that we try to do to minimize baby's pain response to especially bedside procedures, and that they can be very involved in that. I think that's something that we, though, as healthcare providers need to be comfortable with. I know there are people that are very comfortable with having a parent at a bedside when they place a peripheral IV, and then people that are not. And so, there's always, some negotiation that has to go on there. But if you are doing a heel stick, or, we've even had babies, who have had eye exams that the ophthalmologist has let the parent be the support person for that baby, and that's gone really well. I had an ophthalmologist who, again, was skeptical in the beginning when we first started doing this protocol. He thought we were really going to slow him down, and he was not happy about that. But what he found over, doing it for several months was that the quality of his exams were much better. He was getting better information if the baby was calm and not, in that defensive kind of mode. I've seen him do eye exams on with a baby on a mom's lap at times, if he can get a quick look and he's not too worried about a baby, and it's gone really well. So I think it's all about negotiation and trying to pull the families in when you can, and just being honest that babies are exposed, unfortunately, to some things that are painful during the course of their stay in the NICU, but that we try to prevent the pain as much as possible, and that we would like to partner with them when it's possible to help them be the support person for their baby.
Cool. There's a few more, so hopefully I'll just kind of run through the ones I think you can answer pretty quick. So do you like NPAS, and do you use NPAS as a scoring tool for your institution?
I worked at one institution that used the CRI score and the FLAC for older babies, not the NPAS, and where I am now, they do not use the NPAS either.
Okay.
So I've not had a whole lot of experience with the NPAS, unfortunately. I don't love the CRIs, but that's unfortunately what I have the most experience with myself.
What about heat and using heat during painful procedures as
I have
maybe
not
as
had
a distraction?
Experience with that. I know it's out there. There's not as much research as there are, as there is on the topics that I covered today. I know that there are places that use that as an intervention, but I don't have a lot of experience with that one either.
And then somebody mentioned that there's some research out there stating that infants habituate non-nutritive suck and pain if you're offering that. So what do you think about offering non-nutritive suck as a pain mitigator? Yeah,
I mean, I think if you can't offer, I think, first of all, non-nutritive sucking works nicely with administration of sucrose or administration of breast milk as an intervention. But if the baby can't have sucrose and can't have breast milk, I like it. I think it helps keep the baby organized. With any of these interventions, I feel like they can habituate over time. I strongly believe that babies learn pretty well over the course of time, what's coming. And if you're, offering sucrose every time you're going to do something painful, they eventually figure that out. And that's why sucrose is one of the examples that actually stops working over the course of time. It used to be that, we cut sucrose off at around 6 months of age because babies weren't fooled by it anymore. And they started to habituate to it a little bit, and it just wasn't as powerful a distractor as it was for the younger babies. Mm-hmm. I do believe that babies can habituate to any of these interventions, and that, as babies get older, you try different things. Child life, if any of you have child life departments at your institutions, and I know that those are mostly children's hospitals that have a child life specialist present in the NICU. But they're really good at figuring out, especially the distractors, what works for an individual baby. I remember, several years ago, we actually had an older baby who really did very poorly with he had a pick in his arm, and he did really poorly with his weekly PICC line dressing change. And as he got older, the sucrose stopped working, the sucking stopped working, and we had to come up with some new interventions. So we consulted the child life therapist, and she actually came, and this little guy would sit on his mom's lap, and the child life specialist would kind of sit on the opposite side of the arm where his dressing was and read him a book or play with him and sing to him while the nurse was on the other side changing the dressing, and he did really great with that. So I think babies do habituate, and as they get older and as things change, you always need to be reevaluating what works for a specific baby and strategizing to try to figure out how you can modify your plan based on how that baby responds.
And maybe just one final one, breastfeeding during immunizations, etc. So you have an opinion about utilizing?
There's some nice evidence to support that. I just think it's, that's one of the more difficult interventions to operationalize, because people think, how can you possibly have a mom breastfeeding while you're doing some sort of a procedure, right? It's the same thing with skin to skin. Mm-hmm. There have been some very successful studies, that have demonstrated that those interventions are really successful with things like heel sticks. But you've got to have staff that are willing to, give it a shot and try it and feel okay about it. So, yeah, I definitely think there's value if you can get people to do that.
Great.
Thanks again. Back to Kathy Bush. And Lori, thank you so much. Kathy Randall, thank you for helping to work through all those questions. This webinar was brought to you by DandleLION Medical. And again, we're so pleased to have experts like Lori be part of our webinar series. As Lori mentioned in her talk, a 24% solution of sucrose is one of the effective non-farm pain management options. And DandleLION does have an organic, sterile sucrose solution with no additives or preservatives in it. It comes in either orange or purple, in either 1 ml for the small babies or 2 ml for newborns. The vial has an eyedropper tip, so you can be sure the baby is getting the right dose in the right place. If you would like some free samples of our DandleLION Kisses, is what we call them, there will be a place in the evaluation form that you can check a box. Now, in order to receive your free CE, you will need to fill out the webinar evaluation. In the chat area, you can click right on the evaluation link, or once we're finished, you're going to be immediately redirected. Here it comes up on the screen now to the evaluation form if your firewall allows. At the end of the evaluation form, you will receive a link to the CE certificate. If you don't have time to fill out the evaluation right now, or your hospital has blocked access, you will receive an email within the next few hours or maybe even tomorrow morning with a link to the evaluation as well as a link to the recording and the PDF of the slides. If you're viewing as a group, each of you must log into the evaluation form to get the CE. We hope you'll go back and visit the DandleLION Medical website for future webinars and also to see one of our past 27 webinars that are still active and available for continuing education credits. So again, thank you so much for watching, everybody. I hope you have a great weekend, and many thanks to Lori Brittingham again for another great DandleLION webinar.